we start with the blueprint, which is the diagnostic wax-up. If you do have existing tools, you can keep it, but you want to make sure that you contour it based on the desire of your restoration. This is going to give you, of course, the relationship between the soft tissue, the hard tissue, and you can always, this day we scan it if you have done the
sure, he's playing with it now. I'm watching.
here at school.
No, you can't take away from
We actually scan it and you can do all this digital. This is back in the days when we have to do everything WhatsApp. And then we have to collect all this data and put it together. So, of course, as I said, the X-rays, not only the periapicals in the pan, because they cannot give us a three-dimensional view of the bone. We usually have to work with CBCT in a way to actually see the 360 movement of the bone surrounding the area. Sometimes it's very difficult to see where the vocal plate position is because it's too thin, and even with a three-dimensional CBCT, it can be challenging. So you still have to do your probing depth, your clinical examination, and everything that is involved. So what is the restoration selection? And this is, as you see, this is one of the first steps. You need to have this in your head before you actually move forward. You need to decide if you're going to go for a screw retain or cement retain prior that you even place the implant. That's the idea. It should not be that you decide to switch to a cement retain because, oh, well, they mess up the angulation and there's nothing I can do. So you need to have with this game plan in your head before. So for a screw retain, usually we place is the preference for the prosthodontist, and cement retain, it was the preferred for the prosthodontist. Then they switched because the reasoning was prosthodontics likes to have fully control of the occlusal surfaces. When you have screws retains, then you have to add composite, which prosthodontists were not happy about it, and there was a whole discussion. But then, as soon as cement started to create problems, periodontitis problem and all that, then everybody came kind of a consensus of ended up with the screw retain, which is provide less biological complications. However, cement, of course, is always an option if the surgeon or did not follow the instructions or we don't have enough bone to actually provide an screw retain restoration. So the surgical protocols, they were basically divided by 4 different surgical types. So the first one, what we call like type 1 or day 0, is what do you do on the side at that moment. So clearly you can extract into socket preservation, that is basically put some bone grafting and membrane on that side. I usually recommend that we do this only and only and only when they're doing pontic development sites, because it's in a way to preserve the contours of the tissue, the bone, and the soft tissues around it. If I'm going to place an implant later on, I will prefer to go with that one or a type 2 design, which means either place it immediate or early placement. Immediate placement is exact at the same time of extraction, which you extract the tooth, you place the implant. Of course, there's going to be a discrepancy space between the implant and the socket, and we're going to talk about that later on. It's called jumping distance. You're going to have to fill with some bone grafting. Then type 2 is an early implant placement, and this actually was a technique that was discussed by Dr. Busser since 1992. In 1998 is a very old technique. But basically what he said is that you extract the tooth, you let the soft tissue close, and then you re-entry and open and place the implant. That way you guarantee that you have primary closure of the flap. And if you see in immediate placement, you basically have a secondary intention healing because it's an open wound. There's no way that you can approximate this flap. While in the early placement, you can actually have approximation of the flap, and it's supposed to be easier to manage the soft tissue. You have the indications, and basically you just need to wait 4 weeks for healing of the site to re-enter. And then type 3 and 4, that is delayed. There is different currents. Some of them consider delay everything that is after 4 months, some others after 12 or 16 months. To me, everything that is more than 4 months is actually delay already. So let's talk about like the how the tissues behave, and it's one the surgical protocol that you're going to choose is what also it should be related to wound healing 101, how this is related. If you see, for example, for the type 1, which is sucker preservation and immediate, we are going to have the bone, the it's going to start at this day series. It's going to be we're going to have very low bone field. We're going to have high amount of bone recontorn, and the soft tissue is in the stage of healing. Like for healing, for early placement, which is actually 4 to 8 weeks, you're going to see that you're going to have some soft tissue healing already. You're going to have a medium density bone refilling and a very a less amount of bone contortion over time. And then when you go to delayed, you see the soft tissue is stable already at week 4 to 8. So there's no difference in that. Bone filling is going to increase over time, and then the bone contortion is going to be less. But if you see, basically the rich contortion of the area, it will happen between the majority of the recontorting is going to happen between the 4 weeks, the 4 months, 4 weeks after extraction. I don't know if this is clear, but I think this is a very easy graph to try to correlate the behavior of the soft tissue bone and bone recontorting regarding the different implant techniques. So I don't want to go too many into details, but basically the flapless surgeries are when you have to like immediate placement is a flapless surgery. You're not opening a flap. Implants is actually I would say the success is first having a traumatic extractions and having to open, opening flap and make the surgery the faster you can. The longer you wait, the more flap you open, the more you disturb the tissue, the more complicated it's going to get. So for immediate implants, if we do one stage that we actually want to like provisionalize at the same time, you're going to need to have a primary stability above 35 Newton centimeters and usually an intact vocal plate, which is actually the tricky part. It's very difficult to find cases with intact vocal plate. And then if you try to do 2 stages, then yeah, when you have a fenestration fractures or vocal plates that are very small, then you're going to have to do
That's
2 stages. You might not be able to provisionalize immediately because you might get below 35 Newton centimeters of torque. So this is actually a study from, actually Dr. Saito was involved in this study. What they try to do is like which one was the best outcome, and when they do implants, and the first was like no bone grafting, placing the implant and just place healing abutment. And the second was doing the implant and place a provisional with no bone grafting. Then the third and fourth group were actually extracting, placing bone grafting, placing the healing abutment, and placing the provisional. And they find out that the best outcome was actually in group 4, which is where they extract, they place the bone grafting, and they place the provisional. Then when we were talking about the socket, as I was saying, I don't want to go too much into detail in this, but the sockets have different designs. So if you see on type 1, the vocal bone is very high, and it actually will allow you for immediate placement. On type 2 is the ones that we use more for socket preservation because that vocal bone is very low. Both the soft tissue is actually on the right position, and type 3 is actually soft tissue and bone is very low compared to the tooth position. In those are cases that have to go basically for grafting all across. Like there's not even an intention to do any immediate or early placement. So for early placement, as I said, the benefit is that you will extract the tooth, you will let it heal for 4 to 6 weeks. You will wait that the soft tissue actually closes. You place your implant with bone grafting usually because the bone is not mature enough, and then you let it heal. There is some current, like Busser, for example, modified his technique in 2009, and then not only he placed the grafting, he also do a connective tissue at the same time to increase the amount of tissue on the side and get better aesthetic results. So for example, I apologize, but I seen since I'm not running in my computer, it's not showing the actual slide, the actual fonts for this. So I wanted to show you this case, like it's an immediate implant placement with no provisionalization. So this patient came, we decided we were going to extract all the teeth. We were going to place implants. We first make the temporaries with the remaining teeth. And then I want you to pay attention to the way that we manage actually even if the same patient, the same mouth, we actually have different outcomes. And if you see the right side, the extractions were kind of very clean. There was not much alteration of the tissue. Automatically, the teeth were removed, the sockets were debrided. We actually did the bone height and sounding to see what was the position of the vocal bone compared to the soft tissue. The vocal bone was in a very good position. Then we decided to go ahead and place our implants with the grafting. Now, if you see on the last picture, on the right side, we actually have this disturbing of the papilla. Like at the time of the extraction was very traumatic, and we ended up breaking through the papillas in the proximal papillas. So we place the implants on both sides, and then on the central side, we place some bone to do some socket preservation. And look at the other side. We actually have to get some stitches because we needed to approximate the tissue. So you know that side is going to heal by secondary intention. And this was 1 week follow-up when the patient came. He didn't have any complaint. He was able to clean. Didn't have any discomfort. But look at this. You see how both sides behave differently. Like the side that was actually atraumatically extracted and the less that we spend the less time actually heal very fast. This is only 2 weeks follow-up. And it actually, look how it maintains. On the other side that we have more struggle in regarding, even though we actually place it, stitches and we hold it together, the side is going to take longer to actually heal. This is the delivery date. We actually delivered this was ended up with a full arch restoration. Aesthetic was not a big concern for the patient in this case, but you can see over time, of course, that side will heal, and then the tissue also help us to get a very nice result. Now, I want to talk about this case. This is a case that I work and actually combine both flapless. We did immediate placement, and then it was kind of socket preservation, but it was actually implant placement with GBR flapless. Both were flapless. So this patient presented with both entrants were not restorable. As you see, there were very short roots. There was periapical lesions. Patient was not happy about it. When we did the CBCT, we found that the vocal bone wasn't very, very, very nice. You can see that we have some thickness, and even though you might think that it looks very, very narrow, actually that's a very good sign for a vocal bone, especially on the centrals. But we have some issues on some pathology on the apex, and also there was some deficiency a little bit on the apical area. So when we're planning to place the implants, we went and tried to engage the most we can the palatal wall and grafted the area where we were going to place the implant on the medial side with some bone grafting. And all this we were able to evaluate through the CBCT. So we did the waxel first because after we removed the ground, we needed to make sure first that we actually have a good implant positioning, and second that we actually the contours of our final restorations were taken into consideration during the surgery. So in this case, what we did is actually, this is before we have all these 3D printings, all these scanning things. So what we did is we actually did a surgical guide in analog that we were actually able to try it in the patient's mouth before at the moment of the extraction of the tooth. So this is the analog way. You use some GC pattern, and actually we have a metal sleeve to make it restrictive, kind of like the same that we do these days with the 3D printing guys. So you see, we went ahead and we extract first the first tooth. We sound the bone, make sure that the position of the vocal bone was as planned as we have it planned. We verify our surgical guide at this point. We make sure that it actually was engaging the palatal wall as we have it planned. And then we just grafted grafted. We did the IceCon technique. We just placed some grafting bone, placed the membrane, and just let it heal. At this time, the temporary was attached to the number 8. Now, the fact that we do a socket preservation, it doesn't mean that actually, like, there is no, it's going to avoid the area resolve. It actually is going to resolve, and you're still going to have dimensional changes. The only benefit that I see of doing socket preservation is if you're going to do a flapless technique. If you're going to go and open a flap and try to place an implant afterwards, most likely the grafting is going to start coming up. So, and it will extend the time that you're actually will be doing this case. So in this case, because we were going flapless and we were not going to open that area, so we keep it as a with the socket preservation. And as I said, it doesn't prevent the area to collapse. The bone will still collapse, but it works as a scaffold for the area. So as I said, it's more often like even in preserved sites that you do socket preservation at the time of extraction, most likely at the time of placement, you're going to have to come back and graft it again. So there's no actual point to try to do this. And this might be very controversial with periodontics, but the reality is that the literature shows that there is not benefit of doing, it's just extension of the time. So you see, after we extracted, we let it heal. Then we went ahead and we did flapless with our guide, the guide that we use, that we tried in the socket side. So we didn't open any flap. We just went ahead and placed a drying deposition, the implant that we as we have it planned. And then we went ahead and on the other tooth, we removed it, and then we did on that side an immediate placement. So in this area, we'd actually extract the tooth. You can see on the last picture where the ostomy area is. When we're starting the drilling, always trying to engage the palatal wall. And we place the implant. You can see in the middle picture the gap that is called jumping gap is the space between the implant and the bone, in the vocal bone, and that area should be filled with grafting material. And you see both implants were placed on the side with different techniques. And what is important, this grafting area, and what we was talking about the study from Dr. Tarno and Dr. Saito, this comes the concept of dual zone, and it basically means that the area of the implants to the bone is going to be occupied by the grafting material, the bone grafting, and then the soft tissue and above the platform is going to be holding the clot with the provisional. So it means that we have two different zones, the soft tissue or above the platform, and then below the platform and the bone area on the implant side. So this is the dual zone concept that we actually use a lot. So you see, this was the provisional restoration. We were able to do both screw retained restorations, and we were able to load it the same day of the placement. And we were able to provide screw retained restorations. That actually was what we were looking for.
Sure,
and these are the final restorations. After everything heals, we just went ahead and delivered the two final restorations for the patient as we had it planned, screw retained on the centros. And you can see on the right side, as there is still some collapse of the area, regardless that we did bone grafting and that we did flapless surgery. So you always, every time you remove the tooth, you should expect some collapsing. Now let's talk about a little bit of table of context. Are we all okay? Are you guys surviving, or are you falling asleep?
No, not tonight.
Good. Okay. And for prosthetic management, I wanted to bring this case because I know some of you are actually doing orthodontics, and everybody feel like there is no connection between what we learn in dental school and why am I doing ortho and peri and pros and all this. And there's always connection. I mean, you need to know everything a little bit, and there is even connection between orthodontics and implants. So this patient, when they presented, he presented after the ortho treatment. And by the time it came, it's like ortho goes, okay, the patient is ready for implants on the sides.
It's not supposed to.
And when the patient comes, you can take a look. The patient is only biting on the right side on one tooth. So I have to go and say, like, okay, listen, the space looks good, but the occlusion is off. The patient is only biting on one tooth. And this happens a lot with ortho. And if you're doing ortho, please make sure that you actually provide an adequate occlusion. I mean, ortho is not only braces. You actually have to work with occlusion. This is part of your specialty. I can go ahead and place all these implants that I want here, but if I don't have a right occlusion, then this is not gonna work. So what we did is like we actually well, the resident went back and then introduced us a little bit. In the meantime, I start preparing for my planning on my on the upper. And then it's important that you actually remember this is dental anatomy. You need to understand that when ortho send you these patients, you need to tell them how much space you need. And it's not only the space that you have on the crown, you also need the space between the roots. Because sometimes when they're doing the ortho movements, the roots are inclined on the position that is not good for you. If you don't have the space on the root level, how are you planning to place the implants? So you can have an idea when you're actually doing like a PA, an X-ray, a regular X-ray on the position of the roots. But the most accurate way will be actually when you do the CBCT. And as a rule of thumb, this is a dental anatomy book, how width and how long the crowns have to be. And this is what you tell the resident. I just told them at the time, okay, I'm gonna do a lateral. I need around 7 millimeters for a space. That's the minimum that I should have, and it has to be post bilateral. If ortho come and tell you, okay, I cannot tilt the cane anymore, I don't have any more space or whatever, then you might need to work a little bit with reshaping and recontouring the neighbor teeth. But the root position, there's nothing you can do about it. If ortho cannot tilt those turn those roots out of your way, there's no way I can do implants. And that's what actually happened in this case. In this case, actually, the space was extremely narrow. First, the patient has like a missing lateral since forever, and second, she didn't want to go for any grafting procedure. She wanted to get this done. She was very upset. She has been so long in ortho. She was exhausted. So the implant for us in this case was extremely precise. So we use a palatal guide. I actually don't have pictures of that, but we did, since we have the braces on the buccal, we actually did a palatal guide that was what we used to show the different, to do the different drillings. It was not fully guided. We went hand-free, but with a palatal guide. So you see the spaces, it was very narrow, especially on the apex. I don't think I have the x-rays on this, but in the apex we were like, it was one, or that's it. It's just one shot that we have to actually place this implant. And we knew since we were planning this case that this case was gonna end up cement retained. There's no way with the bone width that I have in this case that I was going to be able to actually provide an screw retain restoration. And I discussed with the patient at that time the pros and cons of the different restorations and what she's gonna end, and she was okay. Because at this point she was very frustrated. She just wanted to expedite and finalize the treatment that she has been for so long. So this was the initial. You see how narrow the anterior area is. This is very common on the lateral incisal positions. Our implant positioning at that time, as I said, we already knew that this was going to end up as a cement retain for the position of the maxilla. And as I said, it's okay to have a cement retain implants. It's okay, you have the time, you can discuss with the patient, present it to the patient, the options that some patients are okay with that. Main issue is when you send and refer to a surgeon and then they just just place the implant, whatever, and then it gets back to you, and then you have to go ahead and start seeing how many using your time to actually solve the issue, either for cement retain or angulation or whatever. That's what actually becomes a nightmare.
It's too small though.
So this is when the patient came for the second stage. This is the initial, the implant placement, and then she came and we did the second stage surgery. This is after the healing. And then we went ahead and we didn't provisionalize at that time because we didn't have the primary stability for this case. So we let it heal. Then we came back with the second stage. We let heal the soft tissue for 2 weeks, and then we came ahead and do provisionals. So as we expected, the implants were going to be restored cement retained. So in this case, we did chairside side provisionals, and yes, the access hole for these are like a buckle. But since this is a provisional, we hide them with some composite. They are right there. You cannot see it. These are provisionals. We were starting to shape the tissue for the patient with these provisionals. And then after we show to the patient and the patient is like, oh, I love this, I like how they look and everything is fine, we went ahead and we did something that is called like a customer impression copying technique. So we get these two provisionals that we were working and we're going to talk a little bit about tissue sculpting in a little bit. But basically, we just sculpt the tissue in the positions that we wanted in relationship with the scenes of the central and the canine and all this. So you just get the provisional, you place it in this by registration material, then you remove the provisional, you place the impression copings, you add some acrylic, and then you just trim it, and then you just place those in the patient's mouth. And this is what you're gonna use to make your impression. Now, why is this important? Because if you spend so many appointments and so much time actually developing the soft tissue to have in the right position, the zenith of the margin and all that, the only way that you can copy that is based on having a customized impression copy. You don't have customized impression copying, then the tissue, as soon as you remove the provisional, the tissue start collapsing, and then it's not the same as the one that you actually develop. So in this case, we sent it to the lab, and then we decided that we didn't want it to have. We were going to with PFM at that time on the when we were doing like PFM customized abutments with gold at that time, and we were not very happy to have that margins on that on gold. So we decided that we wanted to do the vocal area and actually customize that. So what we did is like we asked the lab to do the custom abutment for us, but they sent us gold abutments. And gold abutments, they don't have oxidation left, so we could not modify them with ceramics. So we have to send it back, and they actually give us castable metals as the PFM. And at the time, what we did is we just deglazed it. We just add the opaquer because they were gray, they were going to show through. And then we just add and modify our buckle margin the way that with ceramic, the way that we actually wanted to have. Then we just put it in the furnace, we verify it in our cast, and then we check in the patient's mouth. So if you see right here, like the margin, for example, on number 10 was a little bit too high, we adjusted a little bit on the patient mouth, and then we went ahead and sent for fabrications of the crowns. So this is how it ended up after we adjusted in the patient's mouth. And then we sent it and told them, okay, now we want you to do lotus lucidity, lithium disilicate, or Emax crowns. And you see their margin ended up in ceramic. It is very aesthetic margin. You don't have pink, you don't have gray, you don't have any color there that can hide you. And this was the final case. Yes, clearly it could get a little characterizations, but also remember like the teeth dehydrate very fast. And what I think the results were very good. The patient was extremely happy. Now let's talk about soft tissue management, and I think this is my favorite topic. I can be here talking for 3,500 million hours, and I know everybody wants to run by now, but I cannot control myself. So this is soft tissue management is one of I'm obsessed with this. Like literally, I'm just obsessed. And basically, the problem is that when we get implants that are actually not following the shape of the actual tooth that was there before. So if you see, this is like a circular. If I do this, it will draw. No, okay. I don't know if I want to see if I can draw, probably not. Okay, so if you see it's a circular, and then think about it, what's the shape actually of the central incisor at that level? It's more
Dr.
like a
Tovar,
triangular. Yes.
on the left side of like WebEx, there's a little like scribbly line, like all the way to the left on top of that bar. You could draw. You see that?
No.
Put your mouse all the way to the left in the middle. There should be like a little bar of a few options.
I have the thing that because I'm sharing a screen, I'm not. I don't have a full. Yeah, I don't have the full.
All
The
right.
full options here.
Okay. Sure.
No, but that's yeah. Well, oh, never mind. I don't know what I did. I think I'm shit.
Bethany, close. I'm not gonna take this off.
No, but this is yes.
Click on it. Oh man.
Am I still here or I just lost everybody?
We're still here.
No, you're still here. Okay, I don't know what I did with Bethany. I'm sorry. Okay. Anyway, so if you see, this is a circle, and the shape that you want to have is something triangular. So this is actually something that is called soft tissue sculpting, and this is nothing new. This has been in the literature since forever, almost 1992. That is my favorite year. It's 1996, and it's basically you have different ways to actually sculpt the tissue, and that way you will provide aesthetics. And the most common that we always do in fixed prosthodontics is the ovid pontics, and you do you do ovid pontics. So you basically, when you extract the tooth, you do the pontic in a way to preserve the shape and the soft tissue positioning. In implant dentistry, it's the same. We just use it because it's needed for the aesthetic area in order to provide aesthetics. So there are 4 ways. The first one is with the healing abutments. These days, we have different shapes, conicals, squares, straight, different shapes of healing abutments that can help us. But again, it will not follow exactly the shape of the tooth that was there. You have a provisional, which is actually more helpful because you can add, remove, and actually play around until you actually achieve what you want. You could use stock abutments or about final abutments to actually sculpt. But the issue with this is that basically after you deliver an abutment, what are you gonna do? You cannot change it, and then if the tissue move around,
I'm not
you just
gonna
lost
push you. That's so
that
fun.
that it is what it is. It's
All
done.
right, go.
And you can use final restorations, which
Right.
is actually
Let him push you
not the
for a
best
minute.
option. But actually, you have some
Matthew,
patients that
can I
either
hold you?
for time consuming or because they have
Whoa.
medical issues, you have no other option, and you just need to guess with your final restoration where you actually gonna ended up having the soft tissue positioning. And all this is why, because all the soft tissue sculpting madness that I have in my head is just because of emergence profile. And if you remember from the beginning of the presentation, emergence profile for me drive me nuts because if you don't sync the implants enough, I don't have a space for the emergence profile. And if I don't have a space for the emergence profile, the patients ended up with a terrible restoration that there's nothing I can do. It doesn't matter how much tissue I push, I'm never gonna be able to actually solve this issue. So doing this soft tissue sculpting, it not only allows you to contour the soft tissue, but also will allow you to locate the margins of your crown, as you see that we did in the previously case. We were able to actually decide where the margin was going to be, give the provide the synod position, and develop the soft tissue architecture. So in this case, as I say, we changed from the circle to the little triangle, and this is on my what I was starting to push the tissue around, that you can see how that area start to dilate over the time. And this was in the same appointment, so you can see with the very first time that I made this plug like with bad registration, when I removed the cylinder, how small it was until the last one that was the delivered the provisional that I delivered on that time. So you see, the soft tissue actually is very easy to work with. You can push it and you still will you can achieve things in a very fast way. So this time, this what I do. We remove the healing abutment, place the provisional cylinder. You can see the ischemia, and we're going to talk about that in a bit, or blanching, however you want to call it. This was the first temporary I made at that time, and it's not the best, but the patient was very happy, especially for someone that is coming with a ESIC or a removable appliance. Whatever you can give fixed will make the patient really happy. So peripheral ischemia, and this is called temporary peripheral ischemia, is aka blanching, which is not the terminology, but it's basically what it does is like you are just limiting the workflow of the blood, and that's why it gets white. So why is important about this? That you need to make sure that profusion of the blood actually come back. If it doesn't, it can create necrosis. So it should, when you're doing this type of procedures, you want to make sure that it doesn't extend more than the neighbor tooth and halfway of the neighbor tooth, and you want to make sure after 15 minutes the blood come back. And if you leave excessive pressure, you're gonna get necrosis. So don't do this and then send the patient like, oh, okay, this is all lunch. Okay, I'll see you in 2 weeks, and then the patient never gets the profusion back on the area. So you see in this case you see how nice we develop our soft tissue by pushing. This was actually, we did like in 2 appointments. We have another issue here, but I don't want to talk about it on this presentation, but you can see how nice the profile that actually follows whatever root configuration it was there before. And this is where the provisional designs come into play. So basically, when you're doing immediate placements and all anterior cases, we're placing the implants very palatal. So when you're developing your provisional, you have to create what is called an S shape, that it goes from the palatal slightly to the vocal, so that way it can hold the soft tissue. Is what is showing in that little arrow. That's what we call the S shape. On the palatal side, it's going to be very flat. Why? Because basically you have the palatal wall there. So if you don't make it flat, then your provisional is not going to be able to sit all the way. If you're doing immediate placement, it's easier to actually verify your prosthetic components actually sit all the way.
Okay.
If you actually let it heal and come back, you might actually need to go and do some profiling of the area because the soft tissue or the bone might be interfering with your prosthetic components. And always important to have the provisionals extremely polished. And by polishing, this study that was done by Luciskaya at Columbia when we were doing residency, it actually showed that the best polish is with pumice, sequence pumice, and then acrylas or the polishing, high polishing. If you try to use no treatment, look, this is in the microscope, how it looks. The no treatment, how rough the surface is, it will trap plaque. The plaque will inflame this tissue. If you don't have healthy of the tissue, it doesn't matter how much you're trying to sculpt and design and it's never gonna happen. Pumice and water only, it was better, but it still will pack some bacteria. Varnish will make you think, well, if I glaze it, I will get like a smooth surface, and actually not. You get like these bubbles that actually also stain some micro. And the high polishing was the one that looks smoother and have the less addition to the microorganism. And then, of course, you clean it with alcohol. Many people put them in chlorhexidine. You have no idea why. They found no cell addition. If you think yeah, because there's a lot of things in the industry that we do because we saw someone that did it, but we never ask ourselves, like, why am I doing this? No, like, just, because somebody told me something in, I don't know, when I was in first year of dental, and I just keep doing it until the end of the days. And steam it because actually, the steamers that we have in the
Hold
Pros
on.
Lab
What?
actually will help to clean it better than chlorhexidine or whatever. So you see, this is the progression of the case. Of course, this is not something that I did in one appointment as told you, this case was a little bit more complex because the tissue shaping, even though you see the pictures now and you see it's very easy, was very tricky because it's a thin biotype, and we had a lot of things to play around, and we actually make some composites to recontour the central and the lateral to actually provide the right distribution of space. Are we okay, Caroline, or should I stop after this case? Because I think, I don't know, I always make things very wrong. I'm sorry. Okay.
No, I think we're still good to keep going.
Okay. So this is the provisional, and then this was the final check. After we develop all this, of course, like, okay, I'm gonna do my customer impression copy. I wanna send it to the lab because after I put all this effort and all this time to get this beautiful profile, I don't want the lab and send me like an egg to put it there and then mess up all my thing. So we did a customer impression copying, and then we actually did, in this case, neutral coated or anodized abutments. And the reasoning was because we wanted to get a gold color. The gold color tends to be better translucency of the shade than if we go with a titanium or a gray color. And in this case, we wanted to do an IMAX crown because of the staining and the high aesthetic of the patient. So we ended up with this design. I didn't place this implant. The reasoning why we did the cement retained was because if you see the incisal edge position, like the abutment was coming very close to the incisal edge position, and this was a class 2 patient with a deep bite, and we didn't want it to have the screw access so incisally that she could fracture it because the thickness of ceramic was very low, was very small. That's why we ended up with cement retain here. If she wasn't maybe class 1 and there was not such a deep bite, probably we'll have go with screw retain. So in this case, this is you see, we place the abutment. We ask the lab to actually develop the abutment 0.5 millimeters below the margin, and then we just provide our final crown. And I say this result came out good. And then the patient, of course, she decided that she didn't like the white stain that she had there because she didn't like it, so we have to take it out. I'm just like, okay. And then we took it out. This was actually the time of delivery, and this was 1.5 years after. As I said, you see the vocal area, there is collapse. In this case, the technique that was used here was early placement. It was extraction, let it heal, re-entry with implant placement and bone grafting. And you can see, still the area is going to resolve. This case, making it more complicated, the fact that it has a soft tissue, a thin biotype. So, well, more than that, I think the soft tissue stable. Probably if I have to do this case again, I will have done a connective tissue graft and try to increase the thickness of the area before moving to the sculpting space. It doesn't mean that I was going to stop the resorption of the bone. The bone we're going to still resorb, but maybe I was able to keep it more longer over time. Then we have this case. This is actually also an early placement, and what they did in this case is that they did a socket preservation, and then they were expecting that we were going to re-entry and place the implant, and bone grafting was not going to fall. So of course with the decision, with everything was good, we tried to place the implant, and look, all the vocal plane was gone. And so what's really the reasoning what I did the socket preservation? Why did I do socket preservation and I have to wait 4 months for that to heal, and then I have to re-entry and actually have to graft again and then wait 4 more months for this to heal? It made no sense. So if you have to do this case, what will you do? Well, you can extract, let it heal, and then just place implant with grafting at the same time. There's nobody's gonna die because of that. You save some time. And so this is what we did in this case. We just placed the implant, we grafted, and you see all the bone graft came out like poof. And we let it heal. In this case we have a provisional that was like a Maryland bridge design. We make sure that there was no contacts on top of the implant site, regardless that it was buried. It was not actually healing abutment place. Then the last picture was when we came in and re-entry for healing abutment second stage surgery. And then we did like a provisional fabrication. Um, the we actually were able to do a screw retain, and you can see the same thing, the blanching. Here we're dealing with a little bit more difficult case because you have triangular teeth and also a site that was already failed with an implant, so we are expecting some bone resorption and some loss of tissue. But I think the result came very interesting. Then we did exactly the same, and this is why I wanted to show you how we make the impression. We just do the same thing that we did before. We place the implants on the by registration. We pour some acrylic, and then we place it back on the socket. And if you see this, what it's going to do, this white is basically hold the same position that you have in your provisional. Make sure that you have no contact at all on the neighbor teeth, that you can pass a floss freely. There is not even a light contact, because if you have a slight contact on the neighbor tooth, most likely that cupping is not seated all the way. So then you're gonna, this is an open tray impression. You can do in single teeth, you can do also with a closed tray cupping. So then we just make the impression, and you can see it will come the soft tissue, the provisional shape on the impression material. And here we place the analog, and you do your soft tissue pouring normal, like there's nothing happen. What's going to happen is when you get your cast, you're going to end up having the same socket shape that the patient has in the mouth with the provisional. And you can see here the shape. Well, clearly I didn't do very good polishing in this provisional. It really looks terrible. But anyway, the provision, you can see the shape of the copy is exactly as the shape of the provisional that I have. And then the shape of the copy is exactly the shape of the crown that I deliver. And this is very interesting because, guys, you're gonna see, you complain about the lab here. It's gonna take you a very good amount of time to figure it out, the people that you can work with. And that's why I'm very picky about the way that you write prescriptions. If you don't know how to write prescriptions, if you write prefabricate PFM crown, then uh, uh,
Audio.
can you guys hear me? Okay.
I can hear fine. I don't know if anyone else is. Caroline, you might have maybe just reconnect your.
Okay.
We lost you where you said prescription.
Okay. The way that you do the prescriptions, you just put like a fabricate PFM crown. Literally, you're letting the lab to do whatever they want. Like if they want to do novel, when that crown fail or that crown doesn't fit or whatever, the lab is gonna say like, oh well, you didn't tell me what do you want. So that's what is important, that you actually write details prescriptions. So when I send this lab with this soft tissue, I'm very crazy with the lab. Because if I'm spending all this time to actually develop all this soft tissue and I'm writing all my prescriptions and you send me something that actually does not follow what I'm asking you, then just send it back and do it again. Like when the lab sends you, after you develop all this soft tissue, you pour it in the soft cast, and then the lab sends you the crown and they don't have the soft tissue attached to the cast. It's like, what did you do? I mean, that makes absolutely no sense. And as it's gonna take you time, you're gonna see a lot of cases that actually the lab is gonna get upset and whatever, but that's fine. At the end, you're gonna find the person that you're gonna be able to work with and communicate, and it's gonna actually save you a lot of time and money in having to be dealing with lab technicians that actually wants to do whatever they feel like is right. So you see, this case, it actually came with the soft tissue in the position that it was, where I have my margin, what I wanted to see. So I'm absolutely sure that the lab follow whatever I gave them. Then in this case, we actually asked the lab, this is what is called positional jig. Since you know the implants have different positions, it depends of the type of connection. You can have 6, 8, 4, 5, 12, depending of the type of implant. You want to make sure that you actually place this abutment in the same exact position that is placed in the cast, that is exactly the same position that is where the crown is. And if you, there's some labs, some implant companies like maybe Noble, Straumann, that it doesn't affect that much because the discrepancy between one position and the other is so big. It's like 10 degrees, you know, it's like literally you can see, okay, this crown is not gonna fit this way, clearly, because you're gonna see the crown tilted all around. But there is other companies like 3i that have 12 position and the difference in degrees or astro is like a 4 degrees. So sometimes you're not, it's very difficult to actually feel 4 degrees discrepancy in an abutment uh, sometimes. So we use this. Basically, what you do is when you place the abutment, you place this positional jig and then you screw it in the way you're absolutely sure that it's exactly in the same position. You still will take an X-ray to verify it's sitting all the way. So we place it in, we try the abutment, and then we were going to cement the crown. And with this, I'm going to conclude the presentation. And this is the technique that we use for actually control the amount of cement. And as I said, the problem with the cement is that I could be talking about this for 3 hours about cement, but there's two things that I want you to remember. See, first, you need to have 2 millimeters of cement that is actually radiopaque to actually being and that the cement actually fall in the bulk in the interproximal areas for you to actually see it radiographically. So even though we take X-rays, 2 millimeters of radiopaque cement is a humongous amount of cement. It's a lot. Okay. Usually, what you find is like a very thin layers that it cannot even be felted. Okay. So, and the other thing is like, okay, you take X-rays, but you have to have literally 2 millimeters that actually on the good side is on interproximal so you can see it. What about if you have it on buccal or lingual and you didn't actually clean it well? You're never going to see it. So one way is to do this way. So what we do is you get the crown, you place a Teflon tape. It's going to work as a, and this is a what Wani technique 2009. It's nothing new. You know, it's not that we're reinventing literally like that we just discovered something very important. This is real. Many people have used it. You place this Teflon tape, and it will work like the spacer. It will like that's the thickness of the cement that you want in. Then will you do like a abutment? Basically, put some bite registration inside of that Teflon, and then just like a micro brush, and let it set. You're gonna remove that abutment. This white thing, the blue thing in the middle is basically the abutment of the crown. You're gonna peel off the Teflon tape. You're gonna apply the cement, and then you're gonna reposition the abutment inside. You see all the excess of cement that is there. You're gonna clean it, and this is the amount of cement that you're actually gonna get in the crown. Technically, when you place it in the patient's mouth, since you have the same abutment, you should have way less amounts of cement. This is the delivery of the restoration. In this case, it was okay. The patient was very happy. We after we finished, he was like, "Yay!" Because it took him forever to actually get this done. So take home message like 3D implant positioning, management of the soft tissue and hard tissue. Biology will lead you to predictable implant restorations. It's all about time, be picky, patient. Yes, there's sometimes that you're going to spend hours doing this until you master it. And then when you master it, it's going to be very fast. We have the National Prosthodontics Awareness Week on April 18 to 24. We're going to do a very cool exercise with the residents on cases. So I will send an invite for you guys all to come. And finally, this is my hometown. I miss it so much. And I don't know if you guys have questions or if anyone is still asleep or we're all falling asleep. I can see Caroline is awake, but I'm not sure if she's actually like awake because I just see the mask.
Oh.